Okay.
Yeah. So, okay. See, we are studying this urodynamics from part 1. Part 1, part 2, part 3. We are studying this urodynamics, but always with heat. We always feel that this is the most difficult topic and we are not going to get anything from it. We are not going to, we can't be able to solve these problems confidently. Am I right? So always we study this topic with hitch and we are never confident. So what I thought, I am also not expert in urodynamics. I am not a urogynecologist. But what I have studied, I have tried to compile in a one this thing so that at least it will be easy what we want. It doesn't require that we should know everything about urodynamics. But mostly about the incontinence, the urodynamics is all about for the MRCOG. Am I right? So we will start this session. Are you able to see the screen? Huh?
Yes, it is the initial
First,
screen,
first
Mridula.
slide
Yeah.
is there, no? Yeah, but it is not one.
Yeah.
Yes. Okay. Is it more? Come
Yes.
to second slide. Okay. Okay. So first and foremost is what is the definition? Actually, I have compiled it from talk, recent talk of urodynamics and all other material from part 1 and part 2, which is available for us, and some stations and some urodynamic graphs also. Okay. So definition. This definition is from TOG. Oh, the this definition seems very difficult, but when we split in 3-4 parts, it becomes very much easy to remember. So what is it? Exactly, urodynamics is we are doing it to assess the either function or dysfunction of the lower uterine tract. Lower urinary tract. Okay, and these are done are various investigations these are come under this urodynamics. Like it comes routine urodynamics, then ambulatory urodynamics, video urodynamics, urethrophlowmetry. So there are different studies which come in this urodynamics. We can do different types of studies. So these are the observations which are made during a variety of investigations, and with this assess we are going to assess this LUT functions objectively and not by subjectively. Okay, and basically what it includes is the physiological parameters of bladder feeling and voiding. So basically it is an observation made during bladder feeling and bladder voiding. Okay, and what is the bladder feeling? Bladder feeling is called as cystometry, and while voiding studies are known as uroflowmetry. Okay, so basically these two studies, they compile this urodynamics. Okay, and the aim of this urodynamics is to reproduce the pathophysiology and the patient symptoms in this artificial setting. Okay, so are you clear about the definition? It has 4 parts. These are the battery of investigation. These investigations assess the function of the urinary tract, and it assesses this function objectively through various parameters of the bladder feeling and voiding. Okay. Now, when to do this studies? So this is the most important part because these are the recommendation. These are the recent recommendation from NICE guideline 2019. Okay. So when you are required to do this urodynamics, is the first is the before surgical treatment of urge incontinence. Okay. So before conservative treatment, there is no need to do urodynamics. Okay. And when the previous failed surgery is for stress urinary incontinence. And in incontinence, when the predominant type is urge or predominant type cannot be determined. Okay. And the last is in case of stress incontinence, when it is complicated by either apical or anterior vaginal wall prolapse, or it is complicated by voiding dysfunctions. Okay, so these are the only indications where NICE recommends this urodynamic testing. Not other cases, though they don't require urodynamics. Okay, so whenever you are doing any station, if they ask for the investigation, you should specifically tell whether the urodynamics are required in this setting or not. Whether in this diagnosis urodynamics are required before treatment or not, that you should able to understand. So remember well, urge incontinence you have to do before surgical treatment only. For stress incontinence, there is no need. No need to do pure stress incontinence, no need to do your urodynamics before surgical treatment also. Only if it is complicated by prolapse or voiding dysfunction, then only you have to do urodynamic test. And in mixed incontinence, where urge incontinence predominates, or when we are unclear that which type is predominant. So, when not to do. The most important when not to do the urodynamics is pure stress incontinence. Then conservative management of any type of incontinence, and when there is mixed incontinence with stress predominance. So in those cases, you need not do urodynamics. Okay, am I clear till now?
Yes, yes.
Now, what are the prerequisites that you should fulfill before doing this urodynamic study? So first, you should have formulated a clear question, like why this patient wants urodynamics, to confirm the diagnosis or to decide regarding the management. Okay, so you should see for exactly what we are going this urodynamics for this patient. Then you have to take a complete history from the patient regarding her symptoms, and to see exactly what type of incontinence or what type of urinary complaint she has. Then you have to review the medication list, whether she is on any antimuscarinic drugs, whether she is on miragablon, whether she is on any other like anticoagulants or any other risky medications, that you should not do the invasive testing. Okay. The next thing is you have to do the urine analysis to rule out the infection. Urine dipstick test to rule out infection, because if infection is there, you have to abandon the study and you have to treat the infection first. Then you have to do complete clinical examination. In that, you have to do the routine general examination and a detailed abdominal and pelvic examination to rule out any abdominal or pelvic masses, prolapse, any genital atrophy, and you have to also see the pelvic muscle tone. And you have to see if there is any urinary leakage on straining. Okay, and focus neurological examination. Actually, for other part, this neurological part doesn't come much into the focus, because whatever questions or whatever this thing, graphs or whatever the stations we are getting, we are not getting any neurological stations. So, okay, but this is for the completion that you have to do a focus neurological examination also. And most important is you should have a complete bladder diary of 3 days. That is the most important prerequisite, that the bladder diary should be completed for at least 3 days, determining her frequency and voiding chart, and depending upon that, you should have formed a preliminary diagnosis also. And quality of life questionnaires and bother score. So it is this International Continence Society, this recommends this questionnaire should be fulfilled before doing any urodynamic studies. So these are the important prerequisites before doing this any urodynamic studies. Now in consent, the consent should be written. Actually, this urodynamic study, it causes very much embarrassment to the patient, and also it causes significant anxiety and discomfort for the patient. So for that matter, the clinician should be very much sensitive and should the patient with respect, dignity, and clinician should allow the patient privacy and adequate time. So the setting should be private, and the clinician should give adequate time to conduct the study. And if you provide information leaflet before the urodynamics, so at least the patient will know what to expect from the study. Okay. And in the consent, you have to explain the limitations also. So because it does not give you guarantee of the chance of cure, they are not going to tell the percentage from the urodynamic study that surgery, in what percentage of patients the surgery might be curative. Okay. Also, it is unreliable in predicting the adverse outcomes of surgery. And as you all know, there is no therapeutic effect. It is a diagnostic test for that matter. So these are the limitations of this study, urodynamics, that the patient should be made aware of. Okay. Now you have to what should be done for the preparation of the patient. So first they have given is, previously they used to tell that you have to stop any antimuscarinic prior to this urodynamic. So for urgent incontinence, the patient may be taking oxybutynin, tolteridine, darifenacin, like that. So the miragablon, that you have to stop, that they previously used to tell. But now recent recommendation says that there is no need. It is not like no need, but the clinician should decide whether to continue or whether to stop. But it should be documented properly. Whether if she is taking any antimuscarinics or drugs for any overactive bladder, it should be properly documented. Okay. And then, as I told you, urine dipstick must be done, and it should check for infection and hematuria. And if infection is there, the test should be postponed till the infection is treated. Okay. And aseptic condition should be strictly followed. And next is, if there is any evidence of prolapse, then it should be reduced either using a finger, pessary, or speculum. So urodynamics should not be performed when there is a prolapse. It should be always reduced before doing the urodynamic study. Okay. Now see, this is the machine for urodynamics. Can you see my cursor on this
Yes.
on your screen? Can you see my cursor moving?
Yes.
Yes. Yes. Yes.
Okay. So this is the chair for the uroflowmetry. So here the patient will sit. So first component of this urodynamics will be uroflowmetry. That is, patient is asked to void on this uroflowmeter. So patient will void. Here is this the container. It is the rotating flow meter. Okay. So this flow meter will be rotating, and the volume and the speed of the void will be measured in this container. Okay. And so this is the part for uroflowmetry. After the uroflowmetry, the patient will be seated on this chair, and the catheters will be connected, and the monitor will record all the readings. Okay. So this is the machine. This is the settings for this urodynamics. Okay. Now, what are the components of this urodynamic study? So first is the representative uroflowmetry with post-voidal residue. So first uroflowmetry, as I told you, on that chair, patient will sit and void. Then the PVR will be measured either by scan or by inserting the catheter. Okay. Then transurethral cystometry. That is, we are going to insert some catheters and pressure transducers, and we are going to fill the bladder, and we are going to measure the pressure changes. So these are called as pressure flow study. Okay. Am I clear till now?
Yes. Yes.
Yeah.
Yes. Yes.
Yes. So what exactly is done in uroflowmetry? So the patient is asked to void by relaxing and not straining while sitting on a commode over a rotating disc flow meter. As I shown you, that is a rotating disc. On that, a container is kept, and on that container, the patient will void. Okay. So the volume of urine passed per unit time can be assessed in mil per second. Okay. ml per second, giving a maximum flow rate and volume voided that can be displayed graphically. So I will show you the graph so you can understand better. And then afterwards, post-voidal residue can be measured. It can be done either through scan or with a catheter, inserting invasive catheter. Okay. Then shape of the flow curve is obtained graphically on the monitor. So what is this? So this curve is bell-shaped with a rapid upstroke, a curve with continuous flow, a clear maximum flow rate, and quick downstroke. Okay. But the bell or arc, it is not symmetrical always. Actually, what is they usually give the representative graph like a bell-shaped graph, but usually this bell is not symmetrical. Can you see? This is the bell-shaped curve. See, this is not symmetrical, but this is the volume. This is the volume voided, and when this bell we can take it into consideration when the voided volume is more than 200 ml only. Then only we can see the proper graph. If the volume voided is less, the graph is not that representative of our voiding functions. Okay, so voided volume should be at least 200 ml so that we can interpret the graph. Okay, so this is the bell-shaped curve. Here is the Q max. You can see the peak is around 25, 26. Okay, so this is the maximum flow rate, that is 25 ml per second. And this is the voided volume, and this is the bell-shaped rapid upstroke and the downstroke. Okay, so this is the uroflowmetry curve. So why it is important that patient should be relaxed and she should be given privacy. Otherwise, she can do it in like in episodes. She may strain herself, she may pause herself while voiding, and then you are not going to get the representative graph. Okay, so patient should be given a quiet atmosphere. She should be relaxed, and privacy should be given to her while recording the uroflowmetry. It is more important so to get a representative graph of her voiding functions. Now see, this is what we are going to get in the real graph. Okay, so this is the uroflowmetry. Can you see this is the voided volume? It is around almost 450 ml. Okay, so this is the voided volume. It is 450 ml. So it is, yes, we can interpret the graph with this volume. Okay, so we have to see how much volume is voided. So whether we can see interpret this graph or not. Second thing, flow. Flow we can see it is almost around reaching up to 30 ml per second. Okay, so this is a good graph that she has voided nicely and the voiding function is correct. Here you are going to see rise in the P date, that is dead reservoir pressure. It is around 40-45. So while voiding, dead reservoir pressure should be less than 72. I will tell you less than 70. I will tell you afterwards also. Just for this interpretation I am telling you. And there is rise in the vesical pressure also, bladder pressure, but there should be no rise in the abdominal pressure. So this is the voiding cystometry or the uroflowmetry graph. Okay, how you are going to interpret this volume voided, what is the flow in ml per second, and what is the maximum dead reservoir pressure it has achieved. Okay, it should not cross more than 70. So what happens? What are the voiding dysfunctions we can see in this graph in uroflowmetry? Am I clear? Anybody has any doubt?
No, no.
Okay. So we can see several peaks. Several peaks, like graph will not be bell shaped, but these are the several peaks we can see. In which condition this happens? If patient does repetitive straining, okay, repetitive valsalva or repetitive straining, then because of any bladder outlet obstruction or detrusor hypocontractility, her detrusors are not contracting properly, in those cases we may get such graph. Okay, then second is very slow rise. Again, it is a sustained, like it is a box, or it is not a curve, but it will be a flattened box-like shape. So it can be also it also occurs in the urethral stricture or compression from outside, like prolapse. So here the flow will be reduced. It will not be more than 15 ml per. It should be more than 15 ml per second. Normal flow rate should be more than 15 ml per second. If it is less than 15 ml per second and the graph is like box type, then it can be due to a urethral stricture or outside compression of the bladder or urethral. Okay, or sometimes detrusor hypocontractility. Okay, and then sometimes we get it is not bell shaped, it is a triangular large spike of the graph. So it is due to might be due to detrusor overactivity. Okay, so I will tell you in next slide. See, this is the first slide. Here what you can see is it is a it is a very small volume, very small, the bladder flow, that is voiding graph is not proper bell shaped, it is like box shaped, and the flow is also almost less than 10 ml per second. Okay, and detrusor pressure has raised up to 100. Okay, can you see here detrusor pressure has raised more than, almost it is more than 75, and it has in some cases it has raised till 100. Okay, and vesical pressure here, actually abdominal pressure is also more, that means she is straining. Okay, can you see? Sorry, it is not abdominal, it is vesical. So bladder pressure is also more in this case. So this is the case of like outlet obstruction. Okay, so
How much would be the vesical pressure?
actually vesical pressure is raised, but they have not given any limits for the vesical pressure. Only detrusor pressure they have given limits for the voiding cystometry. So it should be less than 70 for detrusor pressure. Okay, so this graph should be, it is like incomplete emptying or slow emptying, and it is maybe because of she maybe have some obstruction. See, if the detrusor pressure has not risen and the flow rate is less, it is detrusor hypocontractility. Okay, but if detrusor pressure is more, as in this case, but the bladder is emptying slowly, then it might be due to obstruction, because the bladder is trying to overcome this obstruction. That's why detrusor pressure is increasing, but she is not able to empty this urine. Got it? So there are two points in this. When we often graph like that, it might be due to hypocontractility. So in hypocontractility, you see here also it is like slow emptying, but here detrusor pressure is very low. Got it?
Yeah.
In second graph, detrusor pressure is very low, so it might be due to detrusor hypocontractility. But in this case, detrusor pressure is very high, so she is straining. She might be straining, or she is trying to overcome this obstruction. So because of that, it might be due to bladder outflow obstruction. Okay. Now, in this third graph, can you see there are repeated spikes? And all this in like abdominal pressure also there are spikes. Vesicle pressure also there are spikes, but detrusor pressure is not rising that much. And while emptying also she has spikes in the flow. So this might be due to repeated valsalva or repeated straining. Okay. So these are the voiding dysfunctions. You have to interpret like that. Okay.
Dr. Mridula, C1 is not clear.
Yeah.
What does it show?
Yes, I will tell you.
Yeah.
See, in this C, whenever we are seeing any voiding graph, voiding cystometry, first we have to see flow. So here flow we are seeing repeated spikes. It is not bell-shaped. Am I right? Repeated spikes are seen in this.
Yeah.
Now we have to see detrusor pressure. Detrusor pressure, it should be less than 70, but it should have increased somewhat. It is hardly 10 or 15. Are you able to see it? So detrusor pressure is less while emptying. So she is not able to raise her detrusor pressure. Okay? Here, vesicle pressure is increased as corresponding to abdominal pressure, and that too in spikes. Abdominal pressure is also raised in spikes. Vesicle pressure is also raised in spikes. Okay? That means she is doing repeated valsalva or repeated straining.
Okay.
And because of repeated straining, she is having these spikes in this flow. And despite of that, she is not able to maintain her detrusor pressure while voiding. Okay?
Okay.
Yeah. So what it can be? See, what it can be? It is caused by either bladder outflow obstruction or unsustained detrusor contraction. Any neurological cause for this hypocontractility, okay, or because of bladder outflow obstruction. Got it?
So basically, the C1 is unsustained detrusor contraction.
Yeah.
C part.
Yeah. C part is unsustained detrusor contraction. Yeah. Might be, or might be due to obstruction also. Here it is because detrusor pressure is not rising, but still we can't tell. Because she is doing repeated valsalva because of obstruction also. We can't tell, no?
Okay.
It will be more this thing with her EMG. There is fourth component. EMG will be there usually, but we are not able to. We are not there to interpret the EMG. Am I right? So neurologic cause we are not very much concerned. Only thing we should interpret what exactly it is. We should tell. If we are able to tell that it is because of either because of detrusor hypocontractility or because of bladder outflow obstruction. This graph is due to repeated straining or valsalva. If this also we tell, it is okay. Okay.
So, Dr. Madhwala, the C will be voiding difficulty. It's showing voiding difficulty.
All are voiding difficulties. All three I am showing is voiding difficulties.
I just joined actually. I just seeing the C only.
Okay. Okay. I will send you recording this afterwards. But all three what I am telling right now is voiding dysfunction only. Okay. What I have told you till now in all graphs, this is voiding dysfunction. It is either due to detrusor contractility dysfunction, either due to urethral dysfunction like stricture or hypermobility or because of outflow obstruction. Okay. So this is just for whatever they have mentioned in POG talk. I have told you it is. I have written here. It is one is suprapubic tapping. When suprapubic area is tapped, it will cause a short bladder contraction, and with straining, it will achieve partial emptying, like whatever we have seen in the C. Okay. So usually in these cases, high PVR. So we have to take into account all the factors, like what is her PVR and everything, and then we can diagnose. Only voiding studies or only pressure studies, we can't diagnose anything. We have to take into consideration all these things. But if you have given such a small graph, then how you have to interpret? How you have to interpret, I am telling. Okay. Okay. Everyone is able to
Okay.
listen. Everyone is able to hear, because I got a message from Anudha that she is not able to listen or hear or see anything. Everyone is clear, no?
Yes,
Everyone
I
is
can.
getting screen and this thing.
Yes, yes, we can listen.
Yeah.
We can listen.
Okay, okay, no problem. Just 1 minute, I will tell her that please log in again. Okay. So, what is the significant PVR? There are no consensus regarding what is the significant PVR. Some book says it is less than 100. It should be less than 100. Some book says it is less than 20. Some book are saying it is less than 50. So there is no consensus of how much should be the exact PVR. Okay. So, but high PVR may be due to either detrusor or hypocontractility. And here you have to take the history of any antimuscarinic drugs, because it will cause urinary retention and it will cause high PVR. Okay. So it should not be, you should not be able to, yes. You should not mix up these conditions. Okay. If she is taking antimuscarinics, a high PVR can be obtained. Okay. Or in case of detrusor failure due to neurological causes or bladder outlet obstruction. So high PVR causes are these. Okay.
Okay.
Yeah. So now next component of this urodynamic study will be the cystometry. So cystometry exact what it does is it shows the bladder storage ability. So here what we are going to do is we are going to insert either two catheters. One is pressure transducer and one is a feeling catheter, or we can insert double lumen catheter. So one has feeling channel and one has pressure transducer. Okay. And here,
It's a feeling study.
yes,
It's a feeling study.
feeling.
Bladder feeling study.
I'm not able to hear you properly. Pardon?
Cystometry is a bladder feeling study.
This is in urodynamics. There are two studies. It is a voiding cystometry, voiding uroflowmetry, and the feeling studies. So we are now talking about the cystometry. It is a feeling study. Okay.
Okay.
Yeah.
Okay.
Yes. Cystometry. We are going to feel the bladder, and we have to insert here two catheters, either two catheters or double lumen catheter. If please unmute yourself.
There is a disturbance.
Yeah. Anyone mute? Hello?
Hello?
Anyone mic is on? Yes. Who is? Yes. Okay. Yeah. So here we are going to insert two catheters or double lumen catheter in the bladder. It will measure bladder pressure. And then another catheter we are going to insert in the rectum. Okay. Now, ICS recommends that the rectal catheter should be primarily used for this abdominal pressure measurement. If it is not at all possible to insert the rectal catheter, then you can insert it either in vagina or in the open stoma, like any colostomy is there on the patient. Then you can insert in that. But primarily, rectal catheter should be used to assess the abdominal pressure. Okay. And now, detrusor pressure, the machine is automatically going to calculate from that. So, detrusor pressure is calculated by minusing abdominal pressure from the bladder pressure. So it is machine is going to calculate automatically. So there will be only two catheters, one in the bladder and one in the rectum. Okay.
Okay. Hello.
Yes, yes. Okay. So see, can you able to see this? So this is the feeling catheter in the bladder. This is the flow meter. Okay. This is the pressure catheter, which will denote the bladder pressure. So this is during feeling phase. This is during voiding phase. See, here is the line. Before the line, it is the feeling phase. After the line is the voiding phase. Okay. And one catheter will be in the catheter means it is a pressure transducer in the rectum. Okay. So it is going to show you the abdominal pressure. Okay. So this is the set how you are going to start your cystometry or feeling studies. So see, this is the usually machine. Here you have to set the machine to 0 all. Okay, so it is the first prerequisite that whenever you insert the catheters, after inserting the catheter, before you starting the study, you should set the machine to 0 all, so that you will avoid the artifacts. Okay, so this catheters, you should not use a thick catheter. So thin catheters like 5 to 7 French should be only used, okay, in the bladder. And the pressures, they can use either fluid filled or air filled or solid state transducers. Okay, so usually it is when we are doing with routine machines, it is a fluid filled system, and the external transducers, they are located at the symphysis pubis, upper edge of symphysis pubis. And exactly what you are going to use in the machine, you have to make a note on your report also. They all should be recorded, like in which position you are recording this cystometry, at what temperature, which fluid you are using, and the feeding rate of the bladder, how much is the feeding rate of the bladder, catheter size, and pressure recording technique. Okay, and in this cystometry, we can use the urethral pressure also. We can measure the urethral pressure also simultaneously in some machines. Not all machines, we can use in some machines. So now when we start, the initial resting pressure should be recorded, and we should see that these are zeroed properly. As I shown you previously, it should be set to 0. Initial resting pressure should be set to 0. Okay. Then the bladder is filled with normal saline at room temperature. Now, at what rate we should fill the bladder? Still, there is no consensus, but what they recommend is 10% of your voided volume. Okay, so if voided volume is 500 ml, we should fill at around 50 ml per minute. Okay, or actually physiological rate is 1 to 2 ml per minute. Bladder filling rate is 1 to 2 ml per minute, but we can use till 10% of the maximum voided volume. Okay, so why it is important? Because rapid filling may cause some inadvertent changes, and we may not get the interpretation correctly. Okay, so we should use the balance between the feeling rate that is slow enough that will cause the physiological feeling, and it will not cause our time waste also. Okay, now exactly what we are going to record on this cystometry graph. What is there? There are so many small letters are there on the cystometry graph. Once I will show you what are the letters. So what are we going to record on this urodynamic graph? So it is the first sensation. When the patient gets first sensation, that is first sensation of feeling. Okay, then first desire to void, that when the moment the patient tells that she wants to go to the toilet but without any hurry. Okay, next is the strong desire to void, it is a SD. So it is the moment the patient she wants to go to the toilet urgently. She doesn't she has that fear of leaking, and she cannot postpone the voiding. Okay, any feeling of urgency, any leak, it should be recorded properly. Okay, so these are the things you have to record. Now you have to tell the patient to cough normally every now and then, like every 2 minutes, every 1 minute, like that. And you have to see why you want to do this is first to see if there is any stress incontinence, and second thing, whether your pressure changes are recording correctly in the graph or not. This is more important to record the pressure changes, because you have to see when the patient coughs, there will be increase in the abdominal pressure, and along with that increase in the vaginal bladder pressure. So it should be same. Okay, so it should produce an acute and equal rise in abdominal pressure as well as bladder pressure, but no or very little rise in the detrusor pressure. Okay, this means that your machine is recording correctly. So there will be no artifacts. Okay, so patient has asked to cough every now and then, like every 1 minute or 2 minutes, like that. Okay, now there are some provocation measures. In case of urgency, if patient has the sensory urgency or something like that, so we have to do this provocative test. So what are these provocative tests? Like jogging, heel bouncing, listening to running water, washing hand, dipping hand in the cold water. Okay, so these are the different positions and different actions that we have to do. We have to ask the patient to do. So that, and they have also, those should be also recorded on the graph. Okay, that at this time patient has jumped, or at this time patient has dipped her hand in the cold water. That we have to record on the graph. So there are settings in the machine for these all actions. So just we have to click the button there. Okay, that patient has done these provocating measures. Okay, and we have to see if there is any changes in the pressure. So now what are the normal values of all these things? So residual urine less than 50. As I told you, there is no common consensus for this PVR, but it should be less than 50 ml. Then first desire to void is between 150 to 200. Okay. Bladder capacity means maximum, that is strong desire to void is between 400 to 600 ml. Okay. So detrusor pressure, it should not rise more than 15 during filling and standing. So detrusor pressure during filling cystometry should be less than 15. Remember this well. It should be less than 15. Okay. There should not be any contractions. Detrusor contraction. Either on provocation, either on resting also. Okay. There should be no detrusor contractions. No leakage on cuffing. And voiding detrusor pressure should not be more than 70. As I told you previously, with a peak flow rate of more than 15 ml per second and voided volume more than 150. Okay. So when the voided volume is more than 150 or 200 and the peak flow rate is 15 ml per second, then the detrusor pressure should be less than 70. Yes. Hello. Okay. Okay. So these are the normal values. These are very much important. We should know all these values. Okay. Clear till now?
Okay.
Yes.
Yes, yes.
Yeah. So now you can see this normal graph. So see, first we have to see exactly which pressures are recorded in which color. So you can see this vesical pressure, that is bladder pressure. They have recorded in the blue line, abdominal pressure in the red line, and detrusor pressure in the green line. Now this is the voided volume, and the orange line, the most down orange line is that is flow rate. Okay. So see this.
Sorry to interrupt you, doctor. In the exam, when they give this urodynamic study, it is in the same
You
pattern,
repeat,
like it will
please.
be colored,
Yeah. No, color we can't tell. Color we can't tell. We have to see.
but it
If
will
they
be
have
like
not
separate
given,
pages.
if they are not given
No,
color, they will
whether
write.
it will be only one page. Like this one page will be showing all the 4-5 values, right?
One page will be showing
Or
4-5.
values like this, the pressure of vesicle, abdomen, detrusor, not separate.
They will write definitely, yeah, on one page only. They will give one graph will be on one page only, and they will write. If they don't, usually they don't give unlabeled. They will write with which is bladder pressure, which is abdominal, and which is detrusor pressure. Okay. They will not give that
Thank you.
unlabeled. Okay. Now see whether this urodynamic is complete or not. First we have to see whether it contains both filling and voiding phase. So can you see this is the filling phase till this? Okay, still this dotted line. Okay, and after this line voiding phase has started. So it is containing both the phases. Okay, it includes all the pressures. Okay. Second thing, it has started from zero. So the machine is zeroed. Okay. Now these are the cuff reflexes. The patient is doing this cuff reflexes at intervals, and at those intervals we are finding this rise in the bladder pressure along with abdominal pressure. Okay.
Okay.
So and then
Okay.
so this is normal. See, with abdominal pressure, if vesical pressure is rise, it is not that it is a stress urinary incontinence, because you have to observe leak for that. To label it as stress incontinence, you have to see a leak. Okay, so this is the normal study. Okay, here can you see this max flow rate is 17 ml per second, volume voided is 600 ml, detrusor pressure is 54, so it is less than 70. Okay, so this is the normal urodynamic chart. Okay, these are actually, this is from the talk, so they can same charts they can give it to you in the interpretation. Okay, these are from the RCOG. This chart is from talk, so same chart they can give you. Here see now one thing. This is first sensation at 172 ml. Okay, and strong desire at 590 ml. So this is also normal. Okay. Now see, this is graph. Can you see first is the vesical pressure? See, somewhat it is unclear, so I am telling you it is the bladder pressure, first line, blue line. Second line is abdominal pressure. Third green line is detrusor pressure. Okay. Then this is the flow, and see here they have not given. See, this graph is whether it is complete or not. Whether it is complete or not.
Complete.
Huh?
Not complete.
Why not complete?
It's not complete.
Why not
The
complete?
voiding
See
part they
there.
have not given.
Yes, voiding part they have not.
Voiding part is
Yes.
And
See,
uroplometry is also.
Yeah. Actually, uroflowmetry, they will give this bell-shaped curve only, but it should at least contain filling and voiding phases, both phases. Okay. So see, can you see here? There is a first whenever we are reporting this thing, first we have to see vesical pressure and detrusor pressure. So first we have to see first is detrusor pressure. Is there any rise or not? So see, here is the rise. So normally there should not be any rise in the detrusor pressure while killing cystometry. Okay. So but it is the rise in the detrusor pressure, and along with that there is rise in the vesical pressure. So this is detrusor overactivity. Okay, it is a DO. Because there is no rise in abdominal pressure but rise in detrusor and vesical pressure. So it is a DO. Now in DO we have to see whether it is with incontinence and without incontinence. Okay. So if the leak is there, see, can you see this leak flow? So there is some leak is observed here. Okay.
Okay.
So it is a detrusor activity along with incontinence. So the urge incontinence in the urodynamics language, it is called as detrusor overactivity. So whenever any graph is given, you should not tell it is an urge incontinence. You should tell it is a detrusor overactivity in case of urge incontinence, and you have to label it whether it is with incontinence or without incontinence. So this you have to tell specifically. You should not tell vaguely that it is urge incontinence. There is no meaning of urge incontinence in urodynamic graph. It is detrusor overactivity either with incontinence or without incontinence. Okay, so interpretation of graph should be like this. Clear?
Yes.
Yeah. So now again this graph. Okay. See whether this graph is complete or not.
Both parts are given here, filling as well as voiding.
Yes. Okay.
But
Correct.
zero, they've given everything with.
Yes, this is complete. Second thing, whether it is see first it has started with zeroing. Okay. Cuff reflex causes same increase in the abdominal and vesical pressure. Okay.
Yes.
Now, so till feeling there is no problem. See, here is the cuff reflex. This is cuff reflex. There is cuff reflex. Okay. Now this is the voiding phase. Now voiding phase. What is the problem? Is there any problem?
There is minimal. Yes, there is minimal voiding, and detrusor and vesical pressure both have increased, but then there is no voiding. So probably it's outflow kind of obstruction.
Yeah, it can be it can be an outflow obstruction or detrusor overactivity during this voiding phase. Okay, hypercontractility.
Yeah.
Because volume voided is very less, even Qmax is very less. Volume voided is very less. Can you see this? And Qmax is very less. So it is a voiding dysfunction. Might be due to obstruction or due to detrusor hypercontractility. Okay. So it is now here you can't say it is a detrusor overactivity because it is in the voiding. It is not in the feeling phase.
Yes.
Okay. Yes. Now
But how,
yes.
Doctor, yeah, in the same group, how would we know that it is a filling phase or it is a voiding phase?
Yes. Now see here. Here they have written. Are you going to able to see this? VO, VO, VO.
Yes.
So this is void. Here again you are seeing this volume is increasing. Yeah. And here also Qmax is increasing. Am I right? So majorly because of VO. This is void. Okay. VO,
And in the
VO,
previous
VO.
class that we showed,
Previous chart.
how would we know?
Yeah.
Yeah, in
Previous
this
chart,
one, yeah.
there is nothing they have mentioned here regarding voiding. Okay. And there is no see. You cannot see the flow. You should see the flow, no, during voiding. So there is no flow. Okay. There is no Qmax.
But this is small rise. That small rise will not indicate.
This is leak.
This is small
This is leak.
Yeah, this. Okay.
Got it? This is leak.
Yeah.
Okay.
Okay. Yeah. Thank you.
Yeah. So now this graph. So whether it is complete or incomplete?
It's a complete graph. No.
Yeah, it is not complete. Voiding part is not there in this graph. Okay. Yeah. So now it has started. Actually, the baseline has not exactly started from 0, but then the detrusor pressure has started from 0. So okay, we can take it. Okay. So this is hard. Is this asterisk is cuff reflex. These are cuff reflex. With cuff reflex, there is both increase in the abdominal and vesical pressure. So pressure recordings are correct in this graph. Okay. They are not artifacts. They are correct recordings. Now, what will be your diagnosis here?
It's a normal kind of filling phase of urometry, because there's rise in detrusor. The rise in detrusor pressure is less than the normal, which is 54, which is 70 centimeters for
No,
normal.
this is the
Then
detrusor overactivity because it's
Ye-
more than 15.
Yes,
Filling
yes.
phase.
It is detrusor overactivity. See, during filling phase, detrusor pressure should be less than 15. Actually, it should not rise at all, but it should be less than 15 if it rises. Okay, so it is more, and it is rising with the raise in the bladder pressure, vesical pressure. The rise is corresponding to the vesical pressure rise. So it is detrusor overactivity. So now one diagnosis is that detrusor overactivity. Whether now we have to see whether it is associated with leak or not. Is it associated with leak? Anywhere they have mentioned regarding the leak, or anywhere in the flow we are seeing there is leak. So there is no leak. But it is detrusor overactivity without incontinence.
Doctor, here there is no voiding phase, na?
Here there is no voiding phase. Yeah. Okay. So there is no need for the voiding phase. There is no need of voiding phase should be recorded for to demonstrate leak, because she can demonstrate leak with detrusor overactivity also. No? Okay. So there the leak will be seen in the flow, or they will write there it is a leak in the graph. Okay. So here it is not associated with any leak, but there is rise in the vesical pressure along with detrusor pressure. So it is a detrusor overactivity without incontinence. It is the complete interpretation of this graph. But here voiding cystometry is not provided. Okay. Now this graph. So, okay, this graph is complete or incomplete?
Complete.
Yes.
Complete.
Yeah. So, now, is there any problem during feeling phase?
No.
Yes.
No, but this.
Yeah. Yes. Any problem during feeling phase? See, first desire to void at 167. A strong desire to void at around 349. So actually it is somewhat less compliant bladder. Okay, it should be around 500. But okay. Okay, strong desire to void, that is bladder capacity is somewhat less. Okay, but okay, if you don't mention also, no problem. Now what is the problem during voiding here?
There is sharp rise in detrusor pressure, and but the voiding volume is very less. So
yes,
it is outflow obstruction probably.
It might be outflow obstruction, correct? Okay, because bladder pressure is more, detrusor pressure is almost around, it is crossing 80, 85, and while Qmax is very less than 10. Even voided volume is only 150. So as I told you, when the voided volume is less, this graph doesn't carry any meaning for that matter. Okay, but this can be reduced bladder capacity also, or it can be high PVR also. So actually the causes we can't tell from here, but we can tell it is a reduced bladder capacity along with a voiding dysfunction. Okay, might be, it can be obstruction or hypercontractile bladder.
Doctor, why reduce bladder capacity? Can you explain, please?
It is 350. Strong desire to void at 350 ml, 349. Got it?
Okay.
It should be 400 to 600. Hmm?
Yes, yes. Okay.
Yeah.
Yes.
Even voided volume, when she has 350 ml is there, voided volume is around 150 only. No.
Okay, so there is residual.
No, voided
So
volume.
residual.
No, voided volume is 350 only. You see, it is 350. It is actually 200 per line. So voided volume is good. There is no residual volume. So yes, it can be this thing also. Okay, because of outlet obstruction, it can be because of she has to strain much. Okay. This graph. Whether this graph is complete or not?
No, not complete.
Why it is complete?
Voiding is
They have given voiding also.
Yes, yes, yes.
It's complete.
Huh?
Yes,
It
yes.
is complete graph.
Yes.
Okay.
Complete.
Yeah, it is complete graph. What is the problem here now? What is the
Detrusor
problem during
overactivity.
feeling?
There is a
Some
Detrusor
bad
overactive.
comparison is there.
Complete diagnosis.
Fluctuating.
Huh?
Yeah, fluctuating.
there is a
Fluctuating pressure.
No. You give me complete diagnosis.
There is a detrusor contract.
overactivity with incontinence.
Yes, it is a
With
detrusor
incontinence.
overactivity in
with
incontinence
incontinence.
because you can see leak here. There is rise in the detrusor pressure, rise in the vesical pressure, but no rise in abdominal pressure. It is during the healing phase. Okay. Now, during voiding phase, can you see the detrusor contractions are not prominent. Detrusor pressure should
Yes.
rise more. It is not rise during voiding phase. Okay. And flow is also less.
Detrusor hypocontractility.
It can be detrusor hypocontractility. Might be she may be using any drugs like anticholinergics for this detrusor overactivity. So it can be a retention of urine also or hypocontractility because of that. We don't know the causes, but it is a detrusor hypocontractility during voiding. Okay, got it?
Okay.
Yes, yes.
See, if you miss something in voiding, then no problem. But at least you should know the correct thing during feeling. Okay, the incontinence diagnosis should be correct. Okay. Just I am telling you voiding because of just to complete this thing. But while feeling phase, your diagnosis should be perfect. Okay. Now see this. So whether it is complete or not, it is complete.
Complete.
Yes. Voiding phase is also there. Feeling phase is there. Okay. Yeah. Now, what is the diagnosis?
Detrusor
Yes.
activity with incontinence.
There is no.
Detrusor
It is not. There is no
less.
incontinence. There is no leak.
There is
Detrusor overactive.
It is only detrusor overactivity without incontinence. Okay.
this. What is this then?
Arrows. They have to demonstrate to this thing.
Just below voiding phase.
Voiding
There
phase.
is
You
some.
can't tell leak on the voiding phase. Leak you have to tell during filling phase only. Because
No,
voiding
but
phase patient is going to void. You can't comment.
no. But I know that, but before that only there is something.
Where? In which line? Which
Yeah,
line?
yeah.
Which line?
This
No, I can't see you. Just tell me. Which line?
below the start.
Below? Start. Actually, this is the.
Below, yeah.
No, this is not leak. This is just they have. It is. I told you this is the graph from the top. This is the start of the study. They have first made it 0, and here they have started feeling phase. Okay.
Okay.
Here they have
Okay.
started the proper graph. See, they will write the leak properly. They will write that it is at proper LEAK. They will write leak. Okay. Otherwise, they will give some changes in the flow, like small this thing. Okay.
Okay.
So leak, you will know it is a leak. Only thing you have to see for it. Okay.
Mm-hmm.
See now this thing.
Stress urinary incontinence. There's a rise in abdominal pressure and there's a rise in vesical pressure and there's a leak.
Yeah, correct. Very good. So, see, this is a complete graph. Feeling phase, voiding phase. Okay. Rise in the vesical pressure, rise in the abdominal pressure, no rise in the detrusor pressure, but leak is seen here. With cuff. See, these are the cuff reflexes. Okay. So cuff reflexes, along with cuff reflexes, there is rise in vesical pressure and abdominal pressure, and same time there is leak. Okay. So this is a what you call it. You should not tell it is a stress urinary incontinence. It is a urodynamic stress incontinence. It is a urodynamic. Terminology for it is urodynamic stress incontinence. You should not tell only stress incontinence. When stress incontinence is demonstrated urodynamically, it is known as urodynamic stress incontinence. Okay, so this terminology you should use. See, again this is. Complete or incomplete? It is an incomplete graph. Voiding.
Incomplete, but there is leak.
Yeah, but the
There is leak.
diagnosis
Stress incontinence.
urodynamic stress incontinence. Use the complete word.
Stress incontinence.
It is
Yeah,
a
urodynamic
stress incontinence. Yes. So now,
Mridula,
yes. Yes.
yeah, in this graph, where is the leak shown here?
See, they have not given any flow. No? How you are going to demonstrate the leak here? So that they have only written it is a leak. Okay. Flow is not there. No? They have not mentioned anywhere. Flow graph is not there. Yes.
They've written leak above there.
Only they have mentioned leak. Because they have not given flow graph. If the flow graph is given, we have to identify the leak. Okay. So now what are the artifacts? So these are the artifacts are inaccurate or spurious measurement that can lead to the failure of interpretation or false negative or false positive findings. So artifacts can occur during any phase. So what happens with uroflowmetry? Because during uroflowmetry, if patient moves or she does the repeated straining, if she has not given privacy, if she is feeling embarrassed, if she is feeling if she is having anxiety, she may move so many times. She may move, she may do the movements or she may do the straining. So it may give rise to some artifacts. While during feeling phase, it is because of due to the catheters. Okay, because of pressure transducer changes. Okay, so maximum time during feeling phase, the artifacts are due to the some catheter position changing, drop of catheter, recording of some rectal contractions. Spontaneous rectal contractions can be also seen. It is rise in the abdominal pressure. So sometimes these artifacts are seen. See, in talk there is a big table on the artifact. No need to remind or by heart that table. Okay. Only thing you should know what are artifacts, which are the artifacts, when the artifacts can be found, and how we have to correct the artifacts. So how to avoid artifacts is initial quality checks of the instrument is very important. Okay. Calibrations, we have to see whether the instrument is calibrated well or not. We have to start from the zeroing, that is zero value should be zeroed before starting the graph. Okay, and continuous checking. How are we going to do continuous checking? Asking the patient to cough. So it will give the simultaneous rise in the vesical and abdominal pressure, but no rise in detrusor pressure. That means the pressure is recording correctly. Okay. Also, we have to see there are no air bubbles in the catheters. Okay. And patient positioning, we have to see the patient is not repeatedly changing the position. And there should be no overriding of the catheters or transducers. Okay. And so all these things are important in preventing the artifacts. Got it? See, in this graph, see, this is again this graph from the top. Can you see this red arrow? There are this zigzag line of this bladder pressure. So these are due to the vibrations. Vibrations, and these vibrations are due to the overriding of catheters, like feeling catheter and pressure transducer. They are in contact with each other. So during feeling phase, when the fluid is going through the catheter, feeling catheter, the pressure transducer is on it, so it is causing the vibrations. Okay. So these are the artifacts. So now how to interpret? Now you are, yes, yes. Any doubt? So how you are going to interpret the report? Right? I told you first we have to see whether the report is complete, whether the graph is complete or not, whether the filling and voiding phase both are there or not. Then next we have to see whether the pressures are zeroed or not at the start of the graph. Okay. Then see for the periodic curve and simultaneous rise of abdominal and vesical pressure. Okay. Then see whether any leak is present. First and foremost thing, once you know that this is the graph, then we have to see whether any leak is present or not. Okay. Now, if there is any leak is present and there is rise in the vesical and abdominal pressure, it will be the urodynamic stress incontinence. Okay. And if there is leak and rise in the vesical and detrusor pressure, it will be detrusor overactivity with incontinence. Okay. And if there is no leak but rise in vesical and detrusor pressure, it is detrusor overactivity. And if the patient tells us that, complains us that if there is sensation of urgency, then it is a DO with sensory urgency. Okay. That is rise in vesical pressure, detrusor pressure, and simultaneously patient is complaining of any urgency. And we have to see if there is any on provocation, like provocation test I told you, like she is jumping or bouncing, jogging, heel bouncing, or dipping her hand in the cold water. At that time, if the detrusor contractions are seen, then it is a provoked detrusor overactivity. Okay. Only on provocation, if the detrusor contractions are seen, it is known as provoked detrusor overactivity. Okay. Then we have to see for any artifacts. If the voiding phase is present, we have to look for any voiding dysfunctions. So this is going to complete our report of the urodynamics, interpretation of the urodynamics. So first we have to tell that it contains both filling and voiding studies, whether it contains or not, the pressures are zeroed or not, and then we have to see whether the pressure recording is correct or not by seeing the simultaneous rise in the vesical and abdominal pressure. And then we have to see for the leak and changes in the pressures. Also, we have to see for provoked detrusor overactivity, see for artifacts, and comment on the voiding dysfunction. So this completes the interpretation of the urodynamics. If we get any graph for the interpretation. Okay? Am I clear? Any doubts? So what are the other tests? This is for the completion only. So what are the other tests that can be done if the patient don't want to get? So it is one is pad test, then video cystometry, ambulatory urodynamics, and urethral pressure studies. So of this, NICE recommends only video cystometry and ambulatory urodynamics. NICE doesn't recommend pad test. According to 2019 guidelines also and previous guidelines also, pad test is not recommended for evaluation of urinary dysfunction. Okay.
Okay.
Till they have mentioned the pad test in detail in the talk. I don't know why, but just for the completion, I'm telling it can be a short-term test or it can be a long-term test. So short-term test is done in the clinic. The patient has been given a pad, okay, pre-weighted pad, and then she has asked to exercise for 30 minutes. And before and after exercise, the pad is weighted. If the gain is more than 1 gram, it is known as a positive pad test. Okay. And long-term test it is usually done at home over 24 to 48 hours. Patient is given pads, pre-weighted pad. Yes. Patient is given pre-weighted pads and the pads she has to change every 4 to 6 hours. Okay. And then they have to be stored in the airtight container or they can be weighed immediately. Any change weight gain more than 1.3 gram is a positive result. Okay. So this is the pad test, but NICE doesn't recommend it. And this pad test will not diagnose which type of incontinence is. Okay. Only thing it will diagnose whether there is a leak or not. But if the patient doesn't want urodynamics to be performed on her, she can be given option of pad test. Now, video cystometry. what we are going to do in video cystometry is they're going to see the same graph as urodynamics, but along with that, they will take fluoroscopic X-rays with contrast medium use, iodine-based contrast. So there is risk of allergy, there is risk of radiation exposure in video cystometry. So this is not done routinely. And it will give us idea of lower urinary tract anatomy also. Okay, so it is more useful for the in our this thing. It is more useful for the diagnosis of bladder diverticulum, urethral diverticulum, if any leak is there. Okay, while doing the feeling graph, we can see if there is any leak is there. Okay. See, can you see this video cystometry picture? This is again from the top. See, can you see these are the outpouching of the bladder? 1, 2, 3. Okay. So these are the bladder diverticulum. Why I'm giving this picture? Because these are from strategy and talk. So they can give you for this result interpretation. They can ask you in exam the same picture they will usually ask. They will not take pictures from outside. No. So they will usually ask the same pictures. Okay. So this is a bladder diverticulum. Now, what is ambulatory urodynamics? So it is usually done outside the clinical settings. It is not done inside the clinic. Okay, and it allows the patient to record these urodynamic studies while doing her day-to-day activities. Because sometimes it may not, while we are doing in laboratory, it may not represent the patient's true symptoms or patient's leakage, because every time she may not leak. She may leak sometimes or sometimes she may not leak. So while doing day-to-day activities, ambulatory urodynamics, to confirm the diagnosis, ambulatory urodynamics may be helpful. Okay. Now urethral function test. No need to know about all these things because they are not at all recommended by NICE. Should not, because the relevance is not yet unclear. So it is not recommended, but only thing they will record. While after doing the cystometry, the catheter is withdrawn slowly from the urethra and it will measure the urethral length and pressure and everything inside the urethra. Okay. But it is not recommended. So actually we need not know this. So girls, this completes the urodynamics. Any doubts?
Thank you, Mridula. It was really nice. It brushed up everything.
Yeah, thank you. Because
Thank you, Dr. Mridula. That's nice presentation. Thank you.
Because we are always feared of this urodynamics. Actually, I read the talk 3-4 days back, and I got to know so many things new. Because I was not knowing this winding dysfunction. I have never prepared for winding dysfunction during my exams. Like just only thing by some typical graphs, I like, there is some bladder outflow obstruction. But why it is that I never studied. And when I was reading this talk, no, like, yes, this is like that. Then I got to know, and then I thought, yes, we should tell others also. Okay. Yes.
Yeah. Thank you so much, Mridula.
Yes. Now one
Yeah,
more.
Mridula, thank you very much.
Thank you.
Thank you. Congrats.
Thank you,
And
doctor.
Thank you. One more thing. Please, girls, post your timings. Actually, Sunday no one opted for. Thursday no one opted for. And Tuesday and Friday, three groups are this thing, asking for this thing, practice. So one group with, I think today who is there? Surabhi. One group is with Surabhi is asking for the practice. One group is Dr. Thin and one group is Sina. That is Shorok and Sina. So these groups are asking, three groups are asking for the same time, Tuesday and Friday 8 p.m. So not possible. Two groups only we can take.
So, Dr. Mridula, for next week, Tuesday, if not possible, then we can do on Thursday, Friday.
See, Friday also it is going to be with three groups actually. So three groups at the same time is not possible.
Like one day. Yeah, I understand. Like one day we can manage. Like Tuesday, okay.
One
The
minute.
group
Now
want
who is
the
talking?
they want
Who is
Tuesday.
talking? Who is talking? I'm
Yeah,
not.
Surabhi.
Surabhi. Okay. Yes. So Surabhi. Okay. So you want one on Tuesday, one on Thursday. Okay. Okay. No problem.
No, Tuesday and Friday. I said.
Yeah. But now
Tuesday and Friday. But
yes,
if not possible, then Thursday, Friday.
Thursday and Friday. Okay, you don't want on Tuesday. Okay, 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 no problem. So I can write with you Thursday and Friday. Okay. And Vishalakshi,
Yeah.
anything you can adjust?
And doctor, we already spoke. It is Thursday and Monday, I think. Monday
Okay.
and Thursday for us.
Monday and Thursday, okay with you? Okay then. So then
Yeah,
we can
yeah,
see.
yeah.
Surabhi, then we will see. We can do on Tuesday, Friday. I will just let you know.
Okay.
If that group is shifted on Monday and
Yeah,
Thursday,
no problem.
if that group is shifted on Monday,
No
and
problem, Dr. Mridula.
yeah,
Yeah,
okay.
if you have some problem, then please let us know. Then we will adjust accordingly.
Definitely, definitely. Okay then. Okay.
Doctor, can I get the recording?
Yes, yes, I have done the recording. I will send you.
Yes,
I have not
because
forgot.
I am on duty. Just now joined.
Okay, okay.
I'm
I have
sorry.
not forgot. I have done the recording. I will send you. Okay.
Thank you. Thank you so much, doctor. Thank you.
Okay then. Bye.
Bye bye.
Bye-bye.
Bye.